Hi, welcome everyone. A couple of things. One is you've noticed I'm first on the agenda, usually I'm last. And when I'm last, it's usually good news, and when I'm first, it's usually bad news. Not that way today. It's actually good news. I'm just really happy I'm not following accreditation, because accreditation is the much more exciting presentation. So, okay, so financials. We are continuing to show strong results. February year to date, so we're 11 months in, one more to go. No surprises on the volume side. If anything, we're surprised at how high our volumes continue to be. And obviously they're impacting everywhere. It's not just Emerge, it's right through the house. So a couple of comments on that. In terms of our financials, so we're just a shade shy of $10 million surplus this year, which is, I think, a record for this organization. Almost $6 million better than planned. But again, as I tell my senior team colleagues, and I tell all the leaders across the organization and staff that I meet, let's not get complacent about this. This is not about us being necessarily extremely efficient or low cost or any of that stuff. Primarily, it's revenue driven. We've done a lot of good things on the revenue side over the last 3 years, and I think you'll recall, for those of you who would listen to me 2 or 3 years ago when I kept saying revenue is a huge opportunity for us. Well, it is, and it has been, and it continues to be. So we've done very well on that, and PCOP revenue, which is the revenue, the funding that we get for new facilities like the birthing center, the RVAP redevelopment, has helped us a lot. We've been able to manage the increased services at a level at which we are funded, and in many cases we're operating at a cost that is less or more efficient than the funded rate, and that's helping us along. So that's really good, because on the expense side, we're starting to see some creep and some exposure. So many of you, I'm sure, are feeling the pinch. We can see our sick time in many areas is high. Overtime, we're using sitters in some areas because of the acuity of our patients. We've got patients with more and more with behavioral issues, and this all costs money. And so we're starting to see our expenses climb. So we got to keep our eye on the ball, and next year is going to be just as tough a year, if not tougher. So that's the bottom line on financials, but the good news is we're going to achieve our plan. We're going to more than achieve our plan. We're going to be able to invest in capital like we've invested in the last couple of years, which is really good news for our patients and for you. So HSFR, Health System Funding Reform. If you've been reading the papers and listening to the news, you know that our funding is going to change, and it's going to change dramatically. So I'm going to give you a flavor beyond what you've heard in the news in terms of what that means for us, and specifically what that'll mean for our institution. HSFR, in a nutshell, we are impacted. Hospitals, obviously, and hospitals have the lion's share of the healthcare budget. CCACs and long-term care homes are going to be impacted. We're going to move from a situation where we basically get fixed funding, about 97% of our funding currently is fixed, to 70% variable. And that's going to happen over 3 years. Next year is going to be 46% variable, so we're going to go from 97 to 46. Almost half of our funding will be variable. It's a huge jump, and then over the subsequent 2 years we're going to get to 70%. Those are the objectives that the government has. Quality, evidence-based care, improved access, so more services to service more patients at lower wait times, and cost containment. And there's a huge emphasis on cost containment, as you can imagine. The budget is about 42% healthcare driven, and they are determined to contain the increase in costs over the coming years. So I'll talk a bit more about that. Two components to the funding formula, something called HBAM, Health-Based Allocation Methodology. It's the latest and greatest formula that they're going to use, and something called Clinical Quality Grouping funding. So, I talked about the 70%. 40% of it is going to be using this new formula. And what it's going to do for every hospital is it's going to compare the actual volume of services that we deliver to the expected level of services that we deliver. So they look at the population and they say, okay, they look at our local population and all the population that we see, and they say, okay, what kind of conditions, what's the age group, what are the common treatments that this population needs, and the volumes, and then they compare to what we actually deliver. If we deliver approximately equal to the demand, then our funding doesn't change on a service level side. If we're delivering lower than those volumes, we are eligible for funding. If we're over-delivering, then we will lose funding. So that's basically how it works. And it's going to basically motivate providers to adjust their service levels to what the demand for those services are. So what we're going to see is we're going to see shifts from one service area to another, depending on what our population needs, which makes sense. And the second part of that is the cost to deliver those services. So they're going to look at what the cost structure is to deliver those services across all the hospitals in Ontario, and they're going to say, okay, where does Rouge Valley fit? If we're around the average, then our funding will be roughly the same on a cost basis. If we're higher than the average, we're going to lose money. If we're lower than the average, we're going to get more money. So they are going to shift funding from one provider to another based on how cost efficient that provider is. So again, it's all about matching services to the demand, and it's about motivating providers to become more and more cost efficient. The second part of it is they're going to focus on specific procedures, and for now we think it's going to be primarily surgical procedures. They're going to look at probably the wait time procedures, and certainly for year one, they're going to look at specifically cataracts, joints, and the other one is actually CKD, chronic kidney disease, which doesn't impact us. But cataracts and joints certainly does. And what they're going to do there is they've analyzed the data across the hospital sector in Ontario, and they've said there's large variation in quality of care, for one thing. So in those areas, cataracts and joints, there are different outcomes from different providers. So some providers do it better than others. The second thing they found is in those areas, there are well-defined evidence-based best practices. So some providers are following them, some aren't. There's large practice variation that could lead to better or worse outcomes. The third thing is they've noticed the cost of providing those particular services is vastly different from one provider to another. Hundreds, sometimes thousands of dollars more expensive or less expensive depending on which provider delivers that service. So what they're saying is that's unacceptable. We've got to find those providers that deliver the highest quality of care at the most cost-efficient rate. And essentially those who cannot produce or deliver those services at a cost-efficient rate with good outcomes will lose funding. And what they're going to do is they're going to set a price that is lower than the price that we currently get funded at for these procedures under wait times. And actually what I've heard is it's going to be significantly lower. So essentially what that's going to do is it's going to shift some of these services from one hospital to another. And what we're going to find is not every hospital is going to provide these services anymore. And for patients, obviously that's going to mean more travel. But hopefully that's going to result in better care at the end of the day to those patients. More cost effective, which the government also wants. Okay, and the last one, how it's going to affect, sorry, I think I've pretty much talked about this. So the big red item here. What does it mean for us? And you're going to find this out as well in the hospital report card, the CIHI data that's hitting the news today. We have done dramatic things to both our quality of care and our cost structure over the last 3 years. We've gone from one of the highest cost providers to somewhere around the middle. And actually, we're not even in the middle. We're kind of less than the middle. Even though our financial results are very strong, they're still not comparable to some of the most cost-efficient hospitals. So what you're going to find on the financial statistics that are published, we're not actually doing that well. So there's a huge opportunity to gain. The bad news about that is, at least in year one, we're actually going to see a funding reduction. So based on this new funding formula, we had actually planned for a slight increase next year. We're actually going to see a decrease. And I'm anticipating we're probably going to see at least a 1% decrease to our base funding. That's never happened before, at least not as long as I've been here. And that basically means that we are less efficient than the average provider in this LHIN. So we've got some work to do. We're on the right track, and thank goodness we're not where we were 3 years ago, or we would have been losing about 2 or 3% in funding next year. So absolutely, we've got to keep up the good work that we're doing, but we're going to have to be better on the cost side. Okay, So, and the challenges. So this is not going to be easy, folks, but we've got a tremendous team. We've done some amazing things over the last 3 years. Those are some of the things that we're going to be grappling with. Limited time for implementation. We're actually not going to know what our funding is until sometime in late April, early May, and then we're going to have to make plans to adjust our services. So cataracts, for example, or joints is significantly lower cost than we're currently funded. We're going to have to make some decisions. Can we become more efficient? And if we can't, we're going to have to give up those services. What does that mean? It's going to have staff impacts, it's going to have physician impacts. There could be a lot of confusion and a lot of stress on the system, and to our patients as well. So we're going to have to be very nimble. And that's it.